Maternal child. Nursing care of newborns, home safety. Provide community resources to patients who might need ongoing assessment and instruction on newborn care. Adolescent parents. Patient education. Never leave the newborn unattended with pets or other small children. Keep small objects like coins out of reach of newborns due to choking hazard. Never leave the newborn alone on a bed, couch, or table. Newborns move enough to reach the edge and fall off. Never place the newborn on the stomach to sleep during the first few months of life. The back lying position is the position of choice. The newborn can be placed on the abdomen when awake and supervised. Never provide a newborn with a soft surface to sleep on, like pillows or a water bed. The newborn's mattress should be firm. Never put pillows, toys, bumper pads, or loose blankets in a crib. Crib linens should be tight-fitting. Do not tie anything around the newborn's neck. Monitor the safety of the newborn's crib. The space between the mattress and sides of the crib, the space between the mattress and the sides of the crib should be less than 2 finger breadths. The slats on the crib should be no more than 5.7 centimeters or 2.25 inches apart. The newborn's crib or playpen should be away from window blinds and drapery cords. Newborns can become strangled in them. The bassinet or crib should be placed on an inner wall, not next to a window, to prevent cold stress by radiation. Smoke detectors should be on every floor of a home and should be checked monthly to ensure that they are working. Batteries should be changed twice a year. Eliminate potential fire hazards. Keep a crib and playpen away from heaters, radiators, and heat vents. Linens could catch fire if they come in contact with heat sources. Control the temp and humidity of the newborn's environment by providing adequate ventilation. Avoid exposing the newborn to cigarette smoke in a home or elsewhere. Secondhand exposure increases the newborn's risk of developing respiratory illnesses. All visitors should wash their hands before touching the newborn. Any individual who has an infection should be kept away from the newborn. Carefully handle the newborn. Do not toss the newborn up in the air or swing them by their extremities. Do not shake the newborn. Nursing care of the patient during the postpartum period. Perineal tenderness, laceration, and episiotomy. Promote measures to help soften the patient's stools. Promote comfort measures. Apply ice or cold packs to the perineum for the first 24 hours to reduce edema and provide anesthetic effect. Do not apply directly to the perineum. Heat therapies, hot packs, moist heat, and sitz baths can be used to increase circulation and promote healing and comfort. Encourage sitz baths at a hot or cool temp for at least 20 minutes for at least twice a day. Administer analgesics, such as non-opioids, like Tylenol, NSAIDs like ibuprofen, and opioids like codeine or hydrocodone for pain and discomfort. Opioid analgesia can be administered via a PCA pump after C-section. Continuous epidural infusions can also be used for pain control after C-section. Apply topical anesthetic cream or spray. Witch hazel compresses to the perineum after cleansing. Witch hazel compresses or hemorrhoidal creams can be applied to the rectal area for hemorrhoid discomfort. Reinforce with the patient about proper cleansing to prevent infection. Encourage the use of distraction, imagery, and other relaxation methods. Patient education. Wash both hands thoroughly before and after voiding. Use a squeeze bottle filled with warm water of antiseptic solution after each voiding to cleanse the perineal area. Blot the perineal area to clean it after toileting, starting from front to back, urethra to anus. Use topical antiseptic cream or spray sparingly. Change the perineal pad by removing the front part first, peeling it toward the back after voiding or defecating. Medical conditions. Hyperemesis gravidarum. Excessive nausea and vomiting, possibly related to elevated HCG levels. That is prolonged past 16 weeks of gestation, or that is excessive and causes weight loss, dehydration, nutritional deficiencies, electrolyte imbalances, and ketonuria. Risk to the fetus for intrauterine growth restriction, small for gestational age or preterm birth if the condition persists. Risk factors: maternal age younger than 30 years old, multifetal gestation, gestational thromboplastic disease, psychosocial issues, and high levels of emotional stress. clinical hyperthyroid disorders, diabetes, gastrointestinal disorders, or family history of hyperemesis. Complications of the newborn. Congenital anomalies. Expected findings. Monitor the newborn for evidence of congenital anomalies. Down syndrome. Oblique palpebral fissures or upward slant of eyes. Epicanthal folds. Flat facial profile with a depressed nasal bridge and a small nose. Protruding tongue. Small low-set ears. Short, broad hands with a fifth finger that has one flexion crease instead of two. A deep crease across the center of the palm, frequently referred to as a simian crease. Hyperflexibility, hypotonic muscles. Neonatal substance withdrawal. Expected findings. Monitor the neonate for abstinence syndrome, withdrawal, and increased wakefulness using the neonatal abstinence scoring system that determines the scores and scores the following. Central nervous system. High-pitched, shrill cry, incessant crying, irritability, tremors, hyperactivity with an increased motor reflex, increased deep tendon reflexes, increased muscle tone, disturbed sleep pattern, hypertonicity, convulsions. Metabolic, vasomotor, and respiratory findings. Nasal congestion with flaring, frequent yawning, skin mottling, retractions, apnea, tachypnea greater than 60 a minute, sweating, and temp greater than 99 degrees Fahrenheit, or 37.2 degrees Celsius. Gastrointestinal findings. Poor feeding, regurgitation, projectile vomiting, diarrhea, excessive, uncoordinated, constant sucking. Newborn data collection. Anogenital. Anus should be present, patent, and not covered by a membrane. Meconium should be passed within 24 to 48 hours after birth. Genitalia of a male newborn should include rug on the scrotum. Testes should be present in the scrotum. Male urinary meatus should be located at penile tip. Genitalia of a female should include labia majora covering the labia minora and clitoris, and are usually edematous. Vaginal blood-tinged discharge can occur in female newborns, which is caused by maternal pregnancy hormones. This is an expected finding. A hymenal tag should be present. Urine should be passed within 24 hours after birth. Uric acid crystals will produce a rust color in the urine the first couple of days of life. Vital signs. Respiratory rates varies from 30 to 60 beats per minute with short periods of apnea less than 15 seconds, occurring most frequently during the rapid eye movement sleep cycle. Periods of apnea lasting longer than 15 seconds should be evaluated. Crackles and wheezing manifestations of fluid or infection in the lungs. Grunting and nasal flaring are clinical findings of respiratory distress. Physical exam from head to toe. Head should be 2 to 3 centimeters larger than chest circumference. If the head circumference is greater than or equal to 4 centimeters larger than the chest circumference, this can be an indication of hydrocephalus, excessive cerebral fluid within the brain cavity surrounding the brain. If the head circumference is less than or equal to 32 centimeters, this can be an indication of microcephaly, abnormally small head. Interior fontanel should be palpable and approximately 5 centimeters on average and diamond-shaped. Posterior fontanel is smaller and triangle-shaped. Fontanels should be soft and flat. Fontanels can bulge when the newborn cries, coughs, or vomits, but should be flat when the newborn is quiet. Bulging fontanels at rest can indicate increased intracranial pressure, infection, or hemorrhage. Depressed fontanels can indicate dehydration. Sutures should be palpable, separated, and can be overlapping molding. A normal occurrence resulting from head compression during labor, caput succedaneum, localized swelling of the soft tissues of the scalp caused by pressure on the head during labor, is an expected finding that can be palpated as soft endometrius mass and can cross over the suture line. Caput succedaneum usually resolves in 3 to 4 days and does not require treatment. Cephalohematoma is a collection of blood between the periosteum and the skull bone that it covers. It does not cross the suture line and results from trauma during birth, such as Pressure of the fetal head against the maternal pelvis in a prolonged difficult labor or forceps delivery. It appears in the first 1 to 2 days after birth and resolves in 28 weeks. Substance use in addictive disorders, opioids. Heroin, morphine, and hydromorphone can be injected, smoked, inhaled, and swallowed. Misuse of prescription opioids for non-medical use has increased in the past few years. Withdrawal manifestations are abstinence syndrome begins with sweating and rhinorrhea, progressing to piloerection, gooseflesh, tremors, and irritability, followed by severe weakness, diarrhea, fever, insomnia, pupil dilation, nausea and vomiting, pain in the muscles and bones, and muscle spasms. Withdrawal is very unpleasant but not life-threatening. Nutrition during pregnancy. Patient education. Reinforce about adhering to and maintaining the following during pregnancy. Increase calories. An increase of 340 calories a day is recommended during the second trimester. An increase of 452 calories a day is recommended during the third trimester. If the patient is breastfeeding during the postpartum period, additional caloric intake is advised. The American Academy of Pediatrics, AAP, recommends that breastfeeding patients who are well nourished should assume 450 to 500 calories a day to a balanced diet. Increasing protein intake is essential to basic growth. Folic acid is crucial for neurological development and the prevention of fetal neural tube defects. Folate found naturally in foods is converted to folic acid. Foods high in folate include leafy vegetable, dried peas and beans, seeds, and orange juice. Breads, cereals, and other grains are fortified with folic acid. The March of Dimes recommends that patients who wish to become pregnant and patients of childbearing age take 400 micrograms of folic acid, and patients who become pregnant take 600 micrograms of folic acid a day. Iron supplements are often added to the prenatal plan to facilitate an increase of the maternal red blood cell mass. Iron is best absorbed between meals and when given with a source of vitamin C, orange juice. Milk and caffeine interfere with the absorption of iron supplements. Food sources of iron include beef, liver, red meats, fish, poultry, dried peas and beans, and fortified cereals and breads. A stool softener might need to be added to decrease constipation experienced with iron supplements. Calcium, which is important to a developing fetus, is involved in bone and teeth formation. Sources of calcium include milk, calcium-fortified soy milk, fortified orange juice, nuts, legumes, and dark green leafy vegetables. Daily recommendation is 1,000 milligrams a day for pregnant and non-pregnant patients, 19 to 50 years old, and 1,300 milligrams a day for those under 19 years old. Evidence-based practice. Use current data to make informed clinical decisions to provide the best practice. Best practice is determined by current research collected from several sources that have desirable outcomes. Use knowledge of evidence-based practice to guide prioritization of care and interventions. Responding to patients experience wound dehiscence or crisis. For example, initiating CPR in the proper steps for a patient experiencing cardiac arrest. Methods to promote evidence-based practice. Use a variety of sources of research. Keep current on new research by reading professional journals and collaborating with other nurses and professionals in other disciplines. Change traditional nursing practice with new research-based practices. Sources of nutrition, vitamins, water-soluble vitamins. Folate is required for hemoglobin, and acid is the synthetic form. Deficiency causes megaloblastic anemia, central nervous system disturbances, and fetal neural tube defects, spina bifida, and encephalopathy. It is important that all patients of childbearing age get an adequate amount of folate due to neural tube formation occurring early in gestation, often before a patient knows they are pregnant. Folate occurs naturally in a variety of foods, including liver, dark green leafy vegetables, orange juice, and legumes. Vitamins and minerals, iron preparations, complication, gastrointestinal distress, nausea, constipation, heartburn. Nursing actions. If intolerable, administer medication with food, but this greatly reduces absorption. Might need to reduce dosage, monitor bowel pattern, and intervene as appropriate. Patient education. Stools can become black or dark green when taken in iron preparation. This usually resolves with continued use. Contraindications or precautions. Concurrent administration of antacids or tetracyclines reduce absorption of iron. Nursing actions. Avoid using antacids within 1 hour after administration of iron. Avoid administration of iron within 1 to 2 hours of tetracycline. Vitamin C increases absorption, but also increases incidence of GI complications. Nursing care of newborns. Medication. Vitamin K. Phenytoin. Administered to prevent hemorrhage disorders. Vitamin K is not produced in the GI tract of the newborn until around day 7. Vitamin K is produced in the colon by bacteria once formula or breast milk is introduced. Nursing actions. Administer 0.5 to 1 milligram IM into the vastus lateralis where muscle development is adequate within 1 hour after birth. Early onset of labor, preterm labor. Medication, nifedipine. Classification and therapeutic intent. A calcium channel blocker that is caused to suppress contractions by inhibiting calcium from entering smooth muscles. Nursing actions. Monitor for headache, flushing, dizziness, and nausea. These usually are related to orthostatic hypotension that occurs with administration. Should not be administered concurrently with magnesium sulfate or immediately following a beta-2-adrenic agonist. Patient education. Slowly change positions from supine to upright and sit until dizziness disappears. Maintain adequate hydration to counter hypotension. Prenatal care. Danger signs during pregnancy. Potential dangerous situations that should be reported to the provider immediately. Second and third trimester. Gush of fluid from the vagina. Rupture of amniotic fluid prior to 37 weeks of gestation. Vaginal bleeding. Placental problems such as abruption or previa. Abdominal pain. Premature labor, abrupto placentae, or ectopic pregnancy. Changes in fetal activity. Decreased fetal movement might indicate fetal distress. Persistent vomiting, hyperemesis gravidarum. Severe headaches, gestational hypertension. Elevated temp, infection. Dysuria, UTI. Blurred vision, gestational hypertension. Edema of face and hands, gestational hypertension. Epigastric pain, gestational hypertension. Concurrent occurrence of flushed dry skin, fruity breath, rapid breathing, increased thirst and urination, and headache, hyperglycemia. Concurrent occurrence of clammy pale skin, weakness, tremors, irritability, and lightheadedness, hypoglycemia. Complication of the newborn, hyperbilirubinemia. Data collection, nursing care. Observe the skin and mucous membranes for jaundice, monitor vital signs, set up phototherapy if prescribed, maintain an eye mask over the newborn's eyes for protection of corneas and retinas. Keep the newborn undressed. For a male newborn, a surgical mask should be placed like a bikini over the genitalia to prevent possible testicular damage from heat and light waves. Be sure to remove the metal strap from the mask to prevent burning. Applying lotion or ointments to the skin because they absorb heat and can cause burns. Remove the newborn from phototherapy every 4 hours. And unmask the newborn's eyes, checking for inflammation or injury. Reposition the newborn every 2 hours to expose all of the body surfaces to the phototherapy lights and prevent pressure sores. Check the lamp energy with the photometer per facility protocol. Turn off the phototherapy lights before drawing blood for testing. Observe the newborn for effects of phototherapy. Bronze discoloration, not a serious complication. Maculopapular skin rash, not a serious complication. Development of pressure areas, dehydration, poor skin turgor, dry mucous membranes, decreased urinary output, elevated temp. Encourage the parents to hold and interact with the newborn when phototherapy lights are off. Monitor elimination and daily weights. Watching for evidence of dehydration. Check the newborn's axillary temp every 4 hours during phototherapy because temp can become elevated. Feed the newborn early and frequently, every 3 to 4 hours. This will promote bilirubin excretion in the stools. Encourage continued breastfeeding of the newborn. Supplementation with formula can be prescribed. Maintain adequate fluid intake to prevent dehydration. Reassure the parents that most newborns experience some degree of jaundice. Explain hyperbilirubinemia. It causes diagnostic tests and treatments to parents. Explain that the newborn stool contains some bile that will be loose and green. Assist with the administration of an exchange transfusion for the newborns who are at risk for chronic teres. Determining fetal well-being. Amniocentesis. Fetal lung maturity. Tests for fetal lung maturity can be performed if gestation is less than 37 weeks. In the event of a rupture of membranes for preterm labor or for a complication indicating a C-section, amniotic fluid is tested to determine whether the fetal lungs are mature enough to adapt to extrauterine life or if the fetus will likely have respiratory distress. Determination is made whether the fetus should be removed immediately or if the fetus requires more time in utero with the administration of glucocorticoids to promote fetal lung maturity. Prenatal care. Preparation for pregnancy and birth. Third trimester. Childbirth preparation. Childbirth classes or birth plan. Coping methods. Breathing and relaxation techniques. Use of effleurage and encounter pressure. Application of heat or cold, touch and massage, and water therapy. Use of transcutaneous electrical nerve stimulation, TENS. Acupressure and acupuncture. Music and aromatherapy. Discussion regarding pain management during labor and birth, natural childbirth or epidural. Use of a doula during labor. Indications of preterm labor and labor. Labor processes, infant care, postpartum care. Fetal movement or kick counts to ascertain fetal well-being. A patient should be instructed to count and record fetal movements or kicks daily. There are several different methods to complete kick counts. One method, patients should count fetal activity 2 to 3 times a day for 2 hours after meals or bedtime. Fetal movements of less than 3 per hour or movements that cease entirely for 12 hours indicate a need for further evaluation. Diagnostic testing for fetal well-being. Non-stress tests, biophysical profile, ultrasound, and contraction stress tests. Medical conditions. Iron deficiency anemia. Lab tests. Hemoglobin less than 11 milligrams per deciliter in the first and third trimesters, and less than 10.5 milligrams per deciliter in the second trimester. Hematocrit less than 33%. Blood ferritin less than 12 micrograms a liter in presence of low hemoglobin. Gestational hypertension. HELP syndrome is a variant of gestational hypertension in which hematologic conditions coexist with severe preeclampsia involving hepatic dysfunction. HELP syndrome is diagnosed by lab tests, not clinically. H equals hemodialysis resulting in anemia and jaundice. EL equals elevated liver enzymes resulting in elevated alanine aminotransferase, ALT, or aspirate transmanase, AST, epigastric pain, and nausea and vomiting. LP equals low platelets, less than 100,000 MM3, resulting in thrombocytopenia, abnormal bleeding and clotting time, bleeding gums, petechiae, and possibly disseminated intravascular coagulopathy. Nursing care of the patient in labor. Presentation. The part of the fetus that is entering the pelvic inlet first and leads through the birth canal during labor. It can be the back of the head, occiput, chin, mentum, shoulder, scapula, or breech, sacrum, or feet. Complications of the newborn. Respiratory distress syndrome. Asphyxia and meconium aspiration. Data collection. Expected findings. Tachypnea, respirations above 60 minutes. Nasal flaring, expiratory grunting, retractions, labored breathing with prolonged expiration, fine crackles on auscultation, cyanosis, unresponsiveness, flaccidity, and apnea with decreased breath sounds. Manifestations of worsened RDS. Complications of the postpartum period. Postpartum hemorrhage. Expected findings: increase or change in lochia pattern, return to previous stage, large clots. Physical findings: uterine atony, hypotonic or boggy, blood clots larger than a quarter, perineal pad saturation in 15 minutes or less, constant oozing, trickling, or flank flow or bright red blood from the vagina. Tachycardia and hypotension, pallor of skin and mucous membranes, cool and clammy with loss of turgor, oliguria. Expected physiological changes during pregnancy, calculating delivery date and determining number of pregnancies for pregnant patient, measurement of fundal height in centimeters from the symphysis pubis to the top of the uterine fundus, between 18 and 30 weeks of gestation, approximate the gestational age plus or minus 2 gestational weeks. Physiological status of pregnant patient, body systems. Cardiovascular. Cardiac output increases 30% to 50%, and blood volume increases 30% to 45% at term to meet the greater metabolic needs. Heart rate increases during pregnancy beginning around week 5 and reaches a peak 10 to 15 a minute above pre-pregnancy rate around 32 weeks of pregnancy. Nursing care of newborns. Medications: erythromycin. Current recommendations regarding prophylactic eye care include the instillation of antibiotic ointment into the eyes to prevent ophthalmia. Neonatorum. Infections can be transmitted during descent through the birth canal. Ophthalmia neonatrium is caused by gonorrhea, chlamydia, trachomatis, and can cause blindness. Nursing actions: use a single dose unit to avoid cross-contamination. Apply a 1 to 2 centimeter ribbon of ointment to the lower conjunctival sac of each eye, starting from the inner canthus and moving outward. A possible side effect is chemical conjunctivitis, causing redness, swelling, drainage, and temporarily blurred vision for 24 to 48 hours. Reassure the parents that this will resolve on its own. Application can be delayed for 1 to 2 hours after birth to facilitate baby-friendly activities during the first period of newborn activity. Breastfeeding. Nursing interventions. Place the newborn skin to skin on the parent's chest immediately after birth. Initiate breastfeeding ASAP or within the first 30 minutes following birth. Reinforce breastfeeding techniques to the parent. Have the parents wash their hands, get comfortable, and have caffeine-free, non-alcoholic fluids to drink. During breastfeeding, reinforce the letdown reflex. Stimulation of maternal nipples releases oxytocin that causes the letdown of milk. Express a few drops of colostrum/milk and spread it over the nipple to lubricate the nipple and entice the newborn. Show the parent the proper latch-on position. Have them support the breast in one hand with the thumb on top and 4 fingers underneath. With the newborn's mouth in front of the nipple, the newborn can be stimulated to open their mouth by tickling the lower lip with the tip of the nipple. The parent pulls the newborn to the nipple with the newborn's mouth covering all or as much of the areola as possible, as well as the nipple. Demonstrate the 4 basic breastfeeding positions. Football hold under the arm, cradle, most common, or modified cradle, across the lap, and side lying. Tell the parents to observe the newborn for cues of fullness rather than being concerned about the time the feeding takes. To prevent nipple trauma, show the parent how to insert a finger in the side of the newborn's mouth to break the suction from the nipple prior to removing the newborn from the breast. Promote rooming and efforts. Offer referral to breastfeeding support groups. Contact the lactation consultant to offer additional recommendations and support, especially to parents who have concerns about adequate breast milk or concerns who have been unsuccessful with breastfeeding in the past. Infections, chlamydia. Nursing care. Instruct the patient to take the entire prescription as prescribed. Identify and treat all exposed sexual partners. Patients who are pregnant should be retested 3 weeks after completing their prescribed regimen. Medical conditions, gestational hypertension. Expected findings, severe continuous headache, nausea, blurred vision, flashes of lights or dots before the eyes. Physical findings, hypertension, proteinuria, periorbital, facial, hand, and abdominal edema, pitting edema of lower extremities, vomiting, oliguria, hyperreflexia, scotoma, epigastric pain, dyspnea, diminished breath sounds, seizures, jaundice, manifestations of progression of hypertensive disease with indications of worsening liver involvement, kidney failure, worsening hypertension, cerebral involvement, and developing coagulopathies. Diabetes, mellitus, and complications. Hypoglycemia and hyperglycemia manifestations and management. Hypoglycemia. Reinforce teaching with the patient about measures to take in response to manifestations of hypoglycemia. Mild shakiness, mental confusion, sweating, palpitations, headache, lack of coordination, blurred vision, seizures, and coma. When glucose declines slowly, manifestations relate to the central nervous system. Headache, confusion, fatigue, drowsiness. With rapid glucose decline, the sympathetic nervous system is affected. Tachycardia, diaphoresis, and nervousness. If the patient is unconscious, place the patient in a lateral position to prevent aspiration and administer glucagon subcutaneous or IM and notify the provider. Repeat in 10 minutes. If the patient is still unconscious, glucagon or IV 50% dextrose is appropriate for patients who cannot swallow. To avoid hypoglycemia, avoid excess insulin. Exercise and alcohol consumption on an empty stomach and eat about the same amounts and at the same time periods daily. Measure blood glucose level if manifestations occur. If it confirms hypoglycemia below 70 milligrams per deciliter, follow the steps below or other protocol outlined by the provider. Provide 15 to 20 grams of a readily absorbable carbohydrate, 4 to 6 servings of fruit juice or regular soft drink, glucose tablets or glucose gel per package instructions, 6 to 10 hard candies or 1 tablespoon of honey. 10 grams of glucose will increase the blood glucose by 40 milligrams per deciliter over 30 minutes. Recheck the blood glucose 15 minutes following intervention and retreat the patient. If manifestations continue or the glucose is not above 70 milligrams per deciliter, if blood glucose is within the expected reference range, have a snack containing a carbohydrate and protein. If the next meal is more than 1 hour away, once consciousness occurs and the patient is able to allow, have the patient ingest oral carbohydrates. Diabetes mellitus, nursing care. Monitor vital signs, blood glucose levels, and factors affecting levels. Other medications, diet, and/or activity. Intake and output and weight. Skin integrity and healing status of any wound. Paying close attention to the feet and folds of the skin. Findings of poor glucose control. Paresthesias, visual changes, recurrent infections. Dietary practices. Exercise patterns. The child's proficiency at self-monitoring blood glucose. The child's proficiency at self-administering medication. Following agency policy for nail care. Some protocols allow for trimming toenails, straight across with clippers, and filing edges with the nail file. If clippers or scissors are contraindicated, the child should file the nails straight across. Reinforce teaching about personal hygiene. Caution the child against wearing sandals, walking barefoot, or wearing shoes without socks. Instruct the child to cleanse cuts with warm water and mild soap. Gently dry and apply a dry dressing. Instruct the child and parents to monitor healing and seek intervention promptly. Reinforce with the child the importance of having medical identification. Examine the child's eyes yearly. Emphasize the importance of regular dental and health care visits. Provide nutritional guidelines. Read labels for nutritional value. Meal planning is based on the requirements of growth and development of the child. Plan meals to match the timing of food to activity and the onset, peak, and duration of anti-diabetic medications. Calories and food composition should be similar each day. Eat at regular intervals and do not skip meals. Count grams of carbohydrates consumed. Recognize that 15 grams of carbohydrates are equal to 1 carbohydrate exchange. Avoid high fat and high sugar or high carbohydrate food items. Use artificial sweeteners in moderation. Reinforce teaching about appropriate techniques for SMBG, including obtaining blood samples, recording and responding to results, and correctly handling supplies and equipment. Assist with an exercise plan. Children active with team sports will require a snack 30 minutes prior to activity. Prolonged activities will require food intake every 45 to 60 minutes. Adjustment in diet and medications can be required with changes in activities. Reinforce illness management guidelines. Monitor blood glucose and urinary ketone levels every 3 hours. Continue to take anti-diabetic agents. However, dosages can differ. Encourage sugar-free, non-caffeinated liquids to prevent dehydration. Meet carbohydrate needs by eating soft foods if possible. If not, consume liquids that are equal to the usual carbohydrate content. Rest. Call the provider if blood glucose is above 240 milligrams a deciliter. Positive ketones in the urine, disorientation or confusion, rapid breathing, vomiting occurs more than once, and if liquids cannot be tolerated. Reinforce manifestations of hypoglycemia, tremors, diaphoresis, anxiety, nervousness, chills, headache, confusion, labile, difficulty focusing, hunger, dizziness, pallor, palpitations. Check blood glucose levels. Follow guidelines outlined by the provider or diabetes educator. Guidelines can include treat with 10 to 15 grams simple carbohydrates, 1 tablespoon sugar. Examples are 4 ounces orange juice, 8 ounces milk, 3 to 4 glucose tablets, or 4 ounces regular soft drink. For mild reactions, use milk or fruit juice. Monitor blood glucose frequently after 15 minutes. If the blood glucose level does not increase by 15 milligrams per deciliter, consume more carbohydrates. Follow with complex carbohydrate. If the child is unconscious or unable to swallow, administer glucagon subcutaneous or intramuscular and notify the provider. Administer simple carbohydrate as soon as tolerated. Watch for vomiting and take precautions against aspiration. Reinforce manifestations of hyperglycemia, lethargy, confusion, thirst, nausea, vomiting, abdominal pain, manifestations of dehydration, rapid respirations, fruity breath. Encourage oral fluid intake. Administer insulin as prescribed. Test urine for ketones and report if findings they remain high. Consult the provider if manifestations persist or progress. Nursing care of the patient during the postpartum period. Urinary retention secondary to loss of bladder elasticity and tone and/or loss of bladder sensation resulting from trauma, medications, or anesthesia. A distended bladder as a result of urinary retention can cause infection, uterine atony, and displacement to one side. The ability of the uterus to contract is also lessened. Postpartum diuresis with increased urinary output begins within 12 hours of delivery. Complications of the newborn, respiratory distress syndrome, asphyxia, and meconium aspiration. Risk factors: preterm gestation, perinatal asphyxiation, meconium staining, cord prolapse, nuchal cord, maternal diabetes mellitus, premature rupture of membranes, maternal use of barbiturates or narcotics close to birth, maternal hypotension, C-section without labor, hydrops fetalis, massive edema of the fetus caused by hyperbilirubinemia, maternal bleeding during the 3rd trimester, hypovolemia. Genetics: white males and second-born twin. Contraception: diaphragm, a dome-shaped cup with a flexible rim made of silicone that fits snugly over the cervix. The effectiveness is increased with the use of a spermicidal cream or gel placed into the dome around the rim. Diaphragms are available in different sizes. Patient education: be properly fitted with a diaphragm by a provider. Replace every 2 years and refit for a 20% weight fluctuation. After abdominal or pelvic surgery and after every pregnancy. The diaphragm requires proper insertion and removal. Prior to coitus, the diaphragm is inverted vaginally over the cervix with spermicidal jelly or cream that is applied to the cervical side of the dome and around the rim. The diaphragm can be inserted up to 6 hours before intercourse and must stay in place 6 hours after intercourse, but for no more than 24 hours. Spermicide must be reapplied with each act of coitus. Empty the bladder prior to insertion of the diaphragm to decrease pressure on the urethra. The diaphragm should be washed with mild soap and warm water after each use. Newborn data collection, vital signs. Expected heart rate ranges from 110 to 160 beats per minute with brief fluctuations above and below this range depending on activity level, crying or sleeping. Apical pulse rate is counted for 1 full minute, preferably when the newborn is sleeping. The pediatric stethoscope head is placed on the 4th or 5th intercostal space at the midclavicular line over the apex of the newborn's heart. Heart murmurs are documented and reported. Complications of the postpartum period, postpartum hemorrhage. Medication, methylargonovine. Classification, uterine stimulant, therapeutic intent. Controls postpartum hemorrhage. Nursing actions. Monitor uterine tone and vaginal bleeding. Do not administer to patients who have hypertension or cardiovascular disease. Monitor for adverse reactions of hypertension, nausea and vomiting, or headache. Medical conditions, gestational hypertension. Anticonvulsant medications. Magnesium sulfate, medication of choice for prophylaxis or treatment to depress the central nervous system and prevent seizures in the patient who has eclampsia and severe preeclampsia. Nursing actions. Use an infusion control device to maintain regular flow rate. Monitor blood pressure, pulse, respiration, deep tendon reflexes, level of consciousness, urinary output, indwelling urinary catheter for accuracy. Presence of headache, visual disturbances, epigastric pain, uterine contractions, and fetal heart rate inactivity. Monitor for manifestations of magnesium sulfate toxicity. Absence of patellar deep tendon reflexes. Urine output less than 30 milliliters an hour. Respiratory rate less than 12 beats per minute. Decreased level of consciousness, and cardiac dysrhythmias. If magnesium toxicity is suspected, notify the RN, immediately discontinue infusion, administer antidote calcium gluconate or calcium chloride, assist with preparing for actions to prevent respiratory or cardiac arrest. Patient education. There can be initial feelings of flushing, heat, sedation, diaphoresis, and burning at IV site with the magnesium sulfate bolus. Early onset of labor, preterm labor, terbutaline. Classification and therapeutic intent. A beta-adrenic agonist that is used as a tocolytic that relaxes smooth muscles and inhibits uterine activity. Nursing actions. Collect data for a history of cardiac disease, pregestational or gestational diabetes, preeclampsia with severe features of eclampsia, severe gestational hypertension, hyperthyroidism, or significant hemorrhage. If the patient has any of these, the medication should not be administered. Monitor for chest discomfort, palpitations, dysrhythmia, tachycardia, tremors, nervousness, vomiting, hypokalemia, hyperglycemia, and hypotension. Notify the RN if heart rate is above 130 beats per minute. Chest pain, cardiac arrhythmias, myocardial infarction, blood pressure below 90 over 60 millimeters of mercury, or pulmonary edema. Administer 0.25 milligrams subcutaneously every 4 hours for up to 24 hours. Discontinue if the patient can't tolerate adverse effects. Hepatitis and cirrhosis. Hepatitis risk factor. Hep B. Route of transmission. Blood risk factors. Unprotected sex with infected individual. Infants born to infected mothers. Contact with infected blood, substance use disorder, injectable substances. Immunizations, immunity. Passive artificial immunity develops after antibodies in the form of immune globulins are administered to an individual who requires immediate protection against the disease after exposure has occurred, following a bite from a poisonous snake or animal who has rabies. After several weeks or months, the individual is no longer protected. Newborn data collection, diagnosis and therapeutic procedures following birth. Expected lab values. Hemoglobin, 14 to 24 grams per deciliter. Platelets, 150,000 to 300,000 mm3. Hematocrit, 44% to 64%. Glucose, 40 to 60 milligrams per deciliter. Red blood cell count, 4.8 times 10 to the 6th power to 7.1 times 10 to the 6th power. Bilirubin, 24 hour is 2 to 6 milligrams per deciliter. At 48 hours 6 to 7 milligrams per deciliter. At 3 to 5 days, 4 to 6 milligrams per deciliter. White blood count is 9,000 to 30,000 mm3. Complications of the postpartum period. Postpartum hemorrhage. Considered to occur if the patient loses more than 500 milliliters of blood after vaginal birth or more than 1,000 milliliters of blood after a C-section. Complications that can occur following postpartum hemorrhage include hypovolemic shock and anemia. Nursing care. Firmly massage the uterine fundus. Monitor vital signs. Monitor for source of bleeding. Palpate fundus for height, firmness, and position. If uterus is boggy, massage fundus to increase muscle contraction. Monitor lochia for color, quantity, and clots. Observe for clinical findings of bleeding from lacerations, episiotomy site, or hematomas. Palpate bladder for distension. Insert an indwelling urinary catheter to check kidney function and obtain an accurate measurement of urinary output. Maintain or assist with initiating IV fluids to replace fluid volume loss with IV isotonic solutions, such as lactated ringers or 0.9% sodium chloride, colloid volume expanders, albumin, and blood products, packed red blood cells, and fresh frozen plasma. Provide oxygen at 10 to 12 liters a minute per non-rebreather face mask and monitor oxygen saturation. Elevate the patient's legs to increase circulation to essential organs. Medical conditions: gestational diabetes mellitus. Patient education. Perform daily kit counts. Adhere to the appropriate diet, including standard diabetic diet and restricted carbohydrate intake. Dietary counseling by a registered dietitian should occur. Exercise. Perform self-administration of insulin. Understand the need for postpartum lab testing to include OGTT and blood glucose levels. Complication of the postpartum period. Uterine atony. Nursing care. Ensure that the urinary bladder is empty. Monitor fundal height, consistency, and location. Lochia for quantity, color, and consistency. Perform fundal massage if indicated. If the uterus becomes firm, continue monitoring. If uterine atony persists, anticipate surgical intervention such as hysterectomy. Express clots that can have accumulated in the uterus, but only after the uterus is firmly contracted. It's critical not to express clots prior to the uterine becoming firmly contracted, because pushing on an uncontracted uterus can invert the uterus and result in excessive hemorrhage. Monitor vital signs, maintain IV fluids, provide supplemental oxygen if needed. Complications of the newborn. Preterm newborn. Nursing care. Perform initial collection of data. Assist with resuscitative measures if needed. Monitor the newborn's vital signs. Determine the newborn's ability to consume and digest nutrients before feeding by breast or nipple. The newborn must have an intact gag reflex and be able to suck and swallow to prevent aspiration. Monitor intake and output and daily weight. Monitor the newborn for bleeding from puncture sites in the GI tract. Ensure and maintain thermoregulation in a newborn who is preterm by using a radiant heat warmer. Manifestations of hypothermia: apnea, cyanosis, hypoglycemia, feeding intolerance, lethargy, irritability, and bradycardia. Assist with the administration of respiratory support measures such as surfactant and/or oxygen administration. Assist with the administration of parenteral or enteral nutrition and fluids as prescribed. Most preterm newborns who are less than 34 weeks of gestation will receive fluids either by IV and/or gavage feedings. Provide for non-nutritive sucking, such as using a pacifier while gavage feeding. Minimize the newborn stimulation. Cluster nursing care. Touch the newborn very smoothly and lightly. Keep lighting dim and noise levels reduced. Position the newborn in neutral flexion with the extremities close to the body to conserve body heat. Prone and side-lying positions are preferred to supine with body containment using blanket rolls and swaddling, but only in the nursery under monitored supervision. Examine skin daily to minimize risk of breakdown. Encourage skin-to-skin contact, kangaroo care whenever possible to reduce preterm infant stress. Protect the newborn against infection by enforcing hand hygiene and gowning procedures. Equipment should not be shared with other newborns. Evidence of infection, temperature instability, lethargy, irritability, cyanosis, bradycardia or tachycardia, apnea or tachypnea, feeding intolerance, glucose instability. Observe the newborn for findings of dehydration or overhydration resulting from IV nutrition and fluid administration. Dehydration, urine output less than 1 milliliter per kilogram an hour. Urine specific gravity above 1.015. Weight loss, dry mucous membranes, absent skin turgor, depressed fontanelle. Overhydration, urine output above 3 milliliters per kilogram an hour. Urine specific gravity below 1.001. Edema, increased weight gain, crackles in lungs, intake greater than output. Nursing care of the patient during the postpartum period. Lochia, post-birth uterine discharge that contains blood, mucus, and uterine tissue. The amount of lochia is similar to a heavy menstrual period about 2 hours after delivery, then decreases gradually at a consistent rate. 3 stages of lochia. Lochia rubra, dark red menstrual period-like discharge that contains debris from the slowing of the uterine lining. It has a bloody consistency and fleshy odor. It can contain small clots. Transient flow increases during breastfeeding and upon rising. Lasts 1 to 3 days after delivery. Remind the patient that they can experience a surge of discharge upon arising after lying in bed for an extended period of time. This should not be mistaken for hemorrhage. Lochia serosa, pinkish brown color and serosanguinous consistency, can contain small clots and leukocytes. Lasts from approximately day 4 to 10 after delivery. Lochia alba, yellowish white creamy color, fleshy odor, can consist of mucus and leukocytes. Lasts from approximately day 10 up to 8 weeks postpartum. Cancer and immunosuppression disorders, nutritional guidelines, and nursing interventions. Cancer, excess body fat stimulates the production of estrogen and progesterone, which can intensify the growth of various cell types and can contribute to breast, gallbladder, colon, prostate, uterine, and kidney cancers. Complications of the postpartum period. Postpartum hemorrhage, medication, misoprostol. Classification, uterine stimulant. Therapeutic intent, controls postpartum hemorrhage. Nursing actions, moderate uterine tone and vaginal bleeding.